All right, once again, good afternoon, everyone, and welcome to today's HI Office Hours session. My name is Sydney Reicher Jensen, and I am MyHealth's Marketing and Communications Coordinator, and I will be today's host. We're so glad you've joined us for today as we dive into this educational session on Oklahoma's statewide HIE and ongoing OKSHINE initiatives and incentive programs. As we kick off today's presentation, I have a few reminders for everyone. Panelists, please mute yourself when you are not actively speaking. Attendees, you are automatically muted in this webinar, so please, to ask a question, utilize the Q&A or the chat function and we'll get to you. And today's presentation will be sent out to all attendees after the session in a PDF format, so please refer to that for any additional information, access to links, or access to contact information. All right, now let's dive into today's topics, Oklahoma statewide HIE and OKSHINE incentive programs. I'd like to introduce our speakers for today, Stephen Miller, Oklahoma State Coordinator for Health Information Exchange, and Patricia Dysinger, Chief Operating Officer and Interim CEO of MyHealth Access Network. We're fortunate to have two such knowledgeable presenters here with us today. So with that, Steve, I'll hand it over to you.
All right, you can advance the slide. Yeah, I really want to thank everyone for being here today, and we're gonna go through this agenda. It's a pretty. I think we can answer most questions in there, but if you have questions, certainly you can put them in the chat, or we can hold them and we'll have a session at the end. I want to walk through really what the HIE is and how it works in Oklahoma. And Patty will give you a good overview of the technical capabilities and what you can actually do inside the HIE. And then we'll go through the programs and incentives, which are some of the best incentives that we've ever had, and talk about some progress we've made and next steps. Next slide. So let's talk a little bit about why change is needed. So, it probably to most of you on the phone, it's not that odd to know that we don't rank very high in Oklahoma for overall healthcare quality. 47th, depends on which article you look at. We've seen us as low as 49th. I've seen us as high as 45th, but we're not as nearly where we'd like to be. We also have the 10th highest healthcare cost in the nation, which is pretty amazing when you think about the rest of our demographics. Um, there's a lot of struggle with fragmented data, and we're going to talk a lot about that today and how the HIE can help that. And this concept that there's a lot of duplicate testing, a lot of medication errors, a lot of delayed diagnosis because that care coordination issue. And we really believe that uncoordinated care really does lead to a lot of these inefficiencies. Disconnected, expensive, and inefficient, and this whole concept of a lack of preventative care. I know we've done several studies recently looking at what the cost savings would be if we could increase the level of preventative care, and it's pretty staggering. And as a other stat that is also for Oklahoma that wouldn't want to be proud of is that we have a higher mortality rate for cancer, despite cancer occurs at about the same rate in Oklahoma as any other state. But if you contract cancer in Oklahoma, you're about 20% more likely to die, which is an interesting issue. And some of that is due to delayed diagnosis and fragmented treatment and some of our health lifestyles. So with that, let's take a look at how we might be able to address this. So, if you're not aware, when we talk about the HIE, sometimes we refer to it as OKSHINE. That was an acronym that was given early in some of the legislative bills that were created, and so we really want to talk about how that it was created and some of the background. Next slide. So, first thing I'd like to say, well, what is a health information exchange? Well, it's a secure system, and that's probably the if you don't take anything else away, understand the HIE is a highly secure system. It's actually uh, governed by and certified by HITRUST, which if you know anything about HITRUST is the highest level of cyber certification that a system can receive. It not only certifies the technology that it's highly secure, but also it certifies the company that operates it in that their policies and the way they operate are also highly secure. It's a lot like 9001, right? You have to not only do the things, but show how you do them. But it is a digital hub where all doctors, nurses, care coordinators, pharmacists, mental health professionals all can coordinate care about their patient. Um, and all that patient access is all done according to HIPAA. In fact, you have to have a HIPAA relationship with a patient to view a record. So it's not just willy-nilly, not anyone can look you up or look someone up in the HIE. You have to have that HIPAA relationship. And actually, the HIE has you actually um, attest to that. So when you look up a patient, it says, "Hey, what's your treatment relationship to this patient?" And you have to attest to that, and we audit that and track that, and so we do quite a bit of efforts to ensure that that security is upheld. Next slide. So just a little bit of background. I spent a lot of time on here, but OKSHINE was created originally by Senate Bill 574 to create the secure statewide health information exchange. Later, the next year in 2022, Senate Bill 1369 was passed that created the Office of State Coordinator. That's my role for HIE and our team who governs the state designated entity, which in this case is My Health, which they received that designation in 2022. Uh, Two other innovative pieces of dates were the Connection Fee Assistance Program, which was launched in late 2023. That provided $21 million to connect anyone in Oklahoma, any provider in Oklahoma, to the HIE at no cost. So we're continuing to run out of that fund. We have dollars available and it's easy to do. We'll talk more about that later. And then the SoonerSelect Provider Incentive Program for managed care. If you see Medicaid patients and you're in managed care, you're eligible for an incentive. That first 15-month pool was 134 million. That closed in June of this year. And I'll talk a little bit more about the payouts on that later. We do have a new pool of funding that is for uh, this fiscal year, and I'll go over that a little bit more later. Next slide. So, how does HIE improve healthcare? Well, it can reduce healthcare costs through reducing redundant testing, reducing hospital readmissions, reducing emergency department visits, really just improve the overall care coordination. I think about when my father was going through kind of his end of life, and I was taking him from his primary care to his cardiologist to his oncologist, and everywhere I'd go, it'd be like a question like, "Well, do you know this lab result? Do you know this injection frac?" All these things that were asking me. And I was a CIO of a hospital at that time, and I didn't know those things. And I said, we're not all interconnected. And that's what really made me say, there's a need for a thing like an HIE. We really need to be able to have our records transportable. So everywhere we go, the providers we see can really have a full view of our care and our last lab results, all those kind of things are available to them without a lot of friction. Um, and from a clinical data standpoint, we really want to improve outcomes and support healthier Oklahomans. And I think that's what the HIE can do the best and help providers save time with instant access to those patient histories versus waiting weeks for a records request or a fax or some of those things. Here at the Healthcare Authority, our nursing team who does all the care coordination, they exclusively use the HIE. They tell me all the time, it used to take us 6 to 8 weeks, to get records. Now we get them instantaneously. The other thing, and Patty will tell you a little bit later about the care fragmentation report, but we get a report every night of where our patients landed. So in other words, every Medicaid patient, if they landed in the ER, they were admitted to the hospital, if they were discharged from the ER, discharged from the hospital, we get that real time. And so we risk score that and we follow up with those patients that next day. Without the HIE, we'd have little to no insights into those kind of activities. Next slide. But probably the biggest reason for HIE is this care fragmentation problem. 90% of Oklahomans have records in more than one health system. I know myself, I think I've got six or seven I can count right now, of different not only health systems but EMR systems that I have that data in. So having that single view of me is going to be very difficult for a physician or provider. Next slide. And we actually took the data in my health and took a look at this issue. So this is all the sixth largest health systems in Oklahoma, and we graphed what's the likelihood that a patient's data that they would have all the patient's data in their own EHR. So if you'll click one more time, Sid. So here, the first column, this is number of chances of one. So in the chance of one, that all the records, I think the largest health system or the largest is 4%. So that health system C, there's a 4% chance that they're going to have all the records. Next slide. The other thing I'm really proud of is that we have one of the highest data densities in our HIE as any other state in the nation. So you can see these really dense red states where they have large numbers of people we have data on. So Oklahoma, Nebraska, Michigan, Indiana, we're really the top four or five as far as data density. If we also look at that though in provider functions that are available in the HI, we are also in the top one or two. So we should really be proud of that. So it's 4.5 million identities, 600 participating organizations. I think it's actually, we're getting well over, very close to 700 participating organizations now in the HIE, over 2,000 participating locations. And there's a 98% chance that when you look up a patient in the HIE, we're going to have data in them. Now we might not always have every single, if they were, were seen in Durant or seen in Guyman, that rural is probably our weakest area, but all the major hospital systems have been sending data for years and most of their connected clinics. So there's a really high chance that we're going to have that data. And the rural health transformation, if you're aware of that, the HI is proposed to be a big part of that. And of course, we won't hear on that officially from the federal government until sometime in January, but hopefully that'll help close those last pieces of the gap to really incentivize rural health providers to be in the HIE as well. Next slide. This is kind of how it works. Organizations send their data directly from their EMR. Sometimes I get the question, well, do we have to type things in and do we have to? It's all automated. So all these data feeds get connected. We work with your EMR provider or your IT department to get feeds from your EMR directly into what we call our data gateway layer. It's kind of our staging layer where MyHealth picks that data up. And I like to kind of help me understand how we're organized. MyHealth facilitates all the outreach and onboarding. They basically do all the operations of the HIE. So the state actually, by legislation, is prevented from operating the HIE. We oversight the HIE, and then we contract a third party, in this case, MyHealth, to do all the governance, to do all the manage the day-to-day operations of that. That data then flows up into the technology layer where it's presented to you, the providers, in a portal view. So you'll see some examples of that in a minute. But it's basically a website you can go to that you can log in securely to and access that data. It looks very much like an EMR. It's aggregated data. So in other words, it's not documents. If you know what a CCD is, we've extracted all that data, so we know the latest blood pressure, we know the latest meds, we know the latest allergies. You can see those, and you can see those even on a timeline. The other thing we offer is single sign-on, and Patty will talk about that also, is that single sign-on capability. So from inside your EMR, you can direct connect to the HIE, and be in one patient's chart and immediately be in the HIE chart with no login and so forth. And then the last layer is, of course, my office's layer. We do all the program oversight. We help manage all the other state agencies and how they use the solution. We do a lot of reporting and analytics, and big thing we do is look for funding and resources. We want to make this as cost effective as we can, and I think with some of the incentives we have right now is extremely cost effective for the value you get in the HIE. Next slide. So just to break it down a little further, so Office of State Coordinator, we select and oversee the state designated entity for health information exchange. We implement the laws and rules related to the HIE. We represent the state in SDE governance, and we seek funding and incentives. The state designated entity, this case, MyHealth, is the stakeholder governed operator of the HIE. They establish policies and procedures. They establish the pricing for the services. They do the outreach and onboarding, and they ensure the patient's rights are protected and all the data stays secure. Next slide. With that, I'm going to turn it over to Patty Dysinger, Interim CEO of MyHealth, and she'll take you through the rest of the story.
Thank you, Steve. As Steve mentioned, we're glad that you joined us today. So I look forward to covering a few more of the topics that Steve touched on in greater detail. And again, just a reminder to drop any questions that you may have into the Q&A session. And also we'll at the end, I think, to field some of those as well in real time. So with that, let's get started. A brief history. I was looking at the attendees, and I think several of you are familiar with the history of health information exchange in the state. Ultimately, MyHealth was founded in 2009 as a nonprofit health information exchange and originated really in the Tulsa area, supporting the providers in an integrated fashion there to improve health outcomes, care coordination, and public health. MyHealth over the years has been funded in various ways, and we are incredibly proud of our partnership with the state that Steve alluded to. As the state designated entity, we've been that since 2022, and it has been an incredible boost for us of ability to staff and deliver additional capabilities. Prior to that, though, ultimately, we were the recipient of the Beacon Community Award to really start operational efficiencies in the beginning and definitely processes and technologies. And then in 2014, merged with SmartNet, very progressive HIE in the state that had been operating for several years. And so that allowed our breadth to expand. And then we are really proud of the fact that much of the initial goals set by the founding organizations have been achieved in terms of us having the ability to demonstrate that there has been improvement in care quality as well as cost reductions and improved patient outcomes as a result of MyHealth being available to clinicians and other members of the care team. So as mentioned earlier, in 2022, MyHealth was named by the state as the state designated entity, and much of that is legislatively supported. And at present, we serve more than 4 million patients in the state of Oklahoma. Next slide. So some of these are visuals that actually build upon others that you've seen. So really just dialing into what Steve shared in terms of data density in the state. We do have over 630 participating organizations across Oklahoma today in MyHealth. And when we use those numbers, you can think that in many instances, a large health system, as an example, is just being counted as one. And so we are really fortunate to have the opportunity to have those trusted relationships with providers and other community organizations to entrust us to capture and aggregate the data so that it can be used by clinicians to improve care. We have literally over 130,000 encounters of information that process daily. So you can think of that as 130,000 combinations of inpatient stays, acute ambulatory visits, lab results, ED stays, et cetera. And we're looking at being at 50,000 plus in terms of unique patient lookups monthly. And we'll talk a little bit more about what that means. But at the heart of our solution is a clinical data repository. And the quickest way to access the information in the exchange is through the provider portal, which is familiar technology to, I'm sure, everyone on the call. So we'll look a little bit more at that in a second, but essentially that's what that 50,000 plus equates to. And again, a really, I think, important fact is that for anyone who is logging into the portal, there is a 98% chance that you're going to find information in the exchange to support whatever patient is before you in terms of treating their care health outcomes, whether it's historical information, whether it is information specifically around family history, or if it is recent clinical transactions that have occurred for that patient. Next slide. What we had on that first diagram was several icons indicating what types of organizations are members of MyHealth, and there are many. And what we've done is put together really kind of a snippet here to help all that are on the call really recognize who all is using the data, who all is a contributor to data in the health information exchange. And so the graphic to the left, I think, really is meant to emulate much of what Steve stated, which is this is an automated process. So electronic health records today, no matter what forum they're in, what care setting they're in, they primarily comply with standards for data integration. And so the tech teams, the vendors know how to connect in a standards-based way around HL7 as an example, around CCDs. And those are the types of data transactions and transmissions that come from these various organizations across the state. So we have hospitals participating in health systems. Many share use cases that we're able to publish later in terms of the outcomes that they experience. We do have data coming in from pharmacies, look to expand that specifically around dispense information, as Steve mentioned, as there are new incredible opportunities on the horizon. We have data from specialty clinics. So if you are looking to close the loop on a referral you've made, there's a high likelihood that whatever specialist you may have referred to, or vice versa, that you'll see information. If you're the specialist taking a referral from a family practice physician, that you would be able to see much of the information that you need to support that new patient intake process. We have behavioral health organizations participating, again, primary care. We have much presence in the rural health community and are thrilled that, especially for patients that transfer from rural communities, potentially as acuity increases into one of the metropolitan hospitals, we also have really that longitudinal record to support there as well. Some use cases you may not think of that could potentially reduce administrative burden experienced by your organization are organ procurement, as an example. We have use cases and are happy to share with you, either through our newsletters or connecting directly, some demonstration of how valuable it is for organizations like LifeShare to be able to look up information in the HIE to really make sure that there's the ability to take advantage of very generous organ donations to make sure that the candidate is actually a good candidate for transplant based off of information in the HIE. Medical examiners, again, speed to processing, they're able to access information as well as EMS. And as we transition to next slide, I just want to reiterate to Steve's point, we trust is at the foundation of what we do. We are governed by our stakeholders, meaning the compliance officers, administrative officers across provider care settings in the state are the ones that are decision making about the use of the health information exchange data. And we work very closely to ensure that the provider to patient attribution is documented and audited within the HIE as well. And so I don't want to leave the opinion that that any of this is done lightly. I want to assure everyone that the appropriate controls and safeguards are in place as well in terms of that patient-provider relationship. Next slide. So I'll briefly cover this here, and then we do have some slides that expand on it, and so I'll try to move quickly. But if you think about what does the MyHealth platform offer, essentially we are now moving towards the language of health data utility and away from health information exchange. What we want to make sure that we do is represent the capabilities properly, where we do have essentially robust health data that supports many use cases, be it public health reporting, be it specifically to support payer programs across the state, if it's really to focus on community-based organizations that may have need across the organization, either supported by SDOH, our social drivers of health tools, or that are services that provide support to those who identify that they need services through some of our SDOH tools. And so we continue to improve the data quality in terms of normalization, because many people across the state document pieces of information differently. And so we focus on improving the data quality and normalizing as well. So at the heart of what we do is really care coordination and records aggregation. And that is done first and foremost. And for those who sign up with MyHealth, you actually can have access to the portal once all of the required paperwork is in place within roughly 7 days. And so at the core of what we do is we intake data, we normalize it into our data warehouse and leverage our identity management solution and aggregate all of the information from the various providers on an individual patient together, so that when you log into the portal, you'll see an aggregated view. And so at the heart is the engine that allows for that. And then what you'll see is various capabilities around that center point that enhance usability. Steve mentioned earlier, care fragmentation reporting as an example. What we'll do is, should you be a provider organization who has a specific patient panel that you track, maybe it's a roster that you have in a value-based program with a payer. Ultimately, what we'll do is share information with you on a daily basis of admissions and or discharges, updates, et cetera, that occurred in the last 24 hours. And then you can choose in your practice whether you want to log into the portal to see that additional information, or if just getting the insight is enough. Again, additional capabilities here. I'll touch on many of them as we move forward. Next slide. This is the provider portal. This gives you just a look and feel of how it's organized. And this is a web-based tool, and working with your client services rep at MyHealth, you will establish a trusted host administrator within your organization. And that is the mechanism by which we can get your organization access to the portal. Very straightforward and really a simplified process. And so much of what we're presenting may seem like it comes with a burdensome process to connect, but it does not. And so we are proud again of our HITrust R2 certification that we achieved in 24. And again, I think that's the key is our responsible management of this data is at the heart. Bottom left shows you what attestation looks like in terms of if you're a clinician that's getting ready to enter a chart because you want to basically do chart prep for a new patient. That's joining your practice. Essentially, what you will do is establish what your connection is to that patient here. And so this is the attestation that gets documented. You can also view on mobile footprint as well, whether it's an iPad or an iPhone. And so it is somewhat reactive and friendly on multiple formats. Next slide. The data is aggregated in the HIE, which is really unique. So many electronic health records or other interoperability frameworks, essentially what you will see is a collection of documents. And so many EHRs generate what's called a continuity of care document, CCD. And if you're looking for a specific data element or hoping that a specific data element, maybe an A1C result, is in that 20-page document, as a clinician or a member of the care team, you might have to thumb through 20 pages looking to see if you can visually scan the A1C. What we do is actually process through our clinical data repository, again, standards-based transmission from your electronic health record, and we parse it into the right places in the chart. So you'll see immunizations aggregated together. You'll see procedures aggregated together, etc. You get the idea. So it looks and feels much more like a native experience that many of you probably know well, which looks just like an electronic health record. Next slide. Single sign-on is a capability that MyHealth invested in 2023, and we continue to advance our deployment. And so right now, if you sign up and you have eClinicalWorks or Epic, several of the big ones that are out there, either in the provider ambulatory setting or in the health system setting, we can work with you to get this set up. But what's nice about it especially is it reduces the number of logins you have to enter, passwords you have to enter, as well as multiple patient lookups. So as an example, back frame here, just pretend that you're logged into your electronic health record. If you're looking at Jane Test's record and you want to see if there's any additional information in the health information exchange, there will be a link placed within your electronic health record here. It's top left under TOC. And once you click on that link, automatically the credentials that you entered into your electronic health record are passed to MyHealth, and then the patient whose chart you're in, that is also passed to MyHealth as well, so that we present that in context without another login. Really great functionality and something we're looking forward to increasing the usability. Next slide. Additional capabilities, we'll just touch quickly. Care fragmentation we talked about. We'll hit on care gaps, e-notifications under conditions of participation from Medicare, and social drivers of health. Next slide. As mentioned, we do have a social drivers of health tool. It's really nifty, and I'll show you a couple of screenshots of it shortly. But we have since 2018 been part of a program. That's when it started, and was initial funding was available. And we built this really novel social needs screening tool, which is based on really a mobile platform. And so since we've offered it, we've issued more than 5.6 million offers to screen to members / patients in the community. We've had 974 plus responses, and 201 of those, more so, 201,000 of those have responded that they do have a need. And of that, essentially 332,000 plus individual needs have been reported. So how it works briefly is we offer either roster-based screening or encounter-based screening. So let's just envision that you're a practice that participates in encounter-based. When a patient presents, you include in your, basically your notice of privacy practices, et cetera, that you participate in MyHealth and offer social needs screening. And so when we receive the information from the registration event, essentially a cell phone number would be offered. And so when the patient is potentially present in the waiting room, waiting to be seen or waiting in the emergency department, et cetera, they'll actually receive the survey on their cell phone based off of the number presented at registration. And they'll answer the normal questions around transportation needs, interpersonal violence, food needs, housing needs, et cetera. And we will return right there on their phone while they're still in practice, local services based off of their zip code. And so you can see here on the right, this is an example of resources in the Mustang area specifically offering food assistance. And so when the patient departs, they actually could go in the community to that location and actually get resources. And again, it rolls up to 3 different options, including in this case, all the way up to the SNAP program with the state. Next slide. We are working with our vendor to ensure that the results from those social needs screenings, those social driver screenings, are made available in the portal. So we're working with our governance process to ensure that everybody understands the implications of exposing this data in the portal. And so this will, I think, support many of the advances that are happening, I think, in the Medicare and Medicaid space. And so having this information at the same place in the chart, essentially, where you have clinical information, I think is what we see as really transformative in terms of having the rest of the story to really support what might be causing potentially concerns with your patients at any given point in time. Next slide. Our care fragmentation learning product, this is what we referenced earlier. Again, we have a portal at the center and that can be used at any point. But once a day, we essentially present you with a data product that lets you know for anyone that you have a relationship with in terms of, again, patient relationship around things like value-based care. If you want to track your high-risk patients to make sure that you know when they're seen in an emergency department, we'll give you this information so that when your intake nurse, et cetera, gets in the morning, they can review this first to see if there's anyone who's been discharged that you potentially need to schedule follow-up on. Next slide. I think the next one is specifically around care gap reporting. In many cases, I think organizations are entering into value-based payments with payers. They also are, you all also are creating your own ACOs and building your preventative programs internally. And so we can work with you to identify what are the measures that matter to you. And we have a relationship with NCQA that we have the value sets for things like adult and children's core, HEDIS, et cetera. And so we'll work together to say on which patient population do you want to track, which measures do you want to track for? And then on a monthly basis, we give you qualifying events out of the health information exchange so that you can close gaps that actually occur beyond the walls potentially of your own organization. Again, this is probably familiar to many, specifically around some of the core measures around, managing diabetes and managing high blood pressure, whether it be preventative mammograms, colonoscopies as an example. Next slide. Lastly, this is a program that's been around for a long time in terms of notification to a primary care physician in the event that a patient is seen in an acute or ED setting. And so this is a routing solution that we offer as well. Very, very pleased with our partnership with Point Click Care in this space, where we actually support this program to meet the expected regulatory requirements. Next slide. A couple of stories that we wanted to share on, again, happy to connect with you and talk about other use cases. But what we do is track our Net Promoter Score. And over time, you will see that we have seen increasing support and really, I think, good feedback in terms of the utilization of the portal and our products. And so here you'll see that we are at a plus 53, which is really incredible. And we've come a long way. This is Q3 2025 results. Here you see a couple of stories from a forensic pathologist in terms of really being able to support their workflow on a quick basis. We have a Creox care manager specifically who is speaking about the comprehensive view of the patients here and ultimately how they can provide better service. And at the right, again, we have a situation where maintaining records becomes increasingly more difficult by the patient population over time. And with My Health really being that longitudinal record, we have that information. And so even data points that folks may forget over time, hopefully you will be able to find some incredibly important and valuable data points that are in the health information exchange to support that care. I think with that, I actually may be passing back at this point, but Sid, let's move forward. Thank you. Back to you, Steve.
Great, thanks. Okay, so how do we make this thing affordable? Well, let's kind of go through some of the incentives that are out there and available to get connected. Next slide. So really there are two incentives that you can receive. The first one is connection fee assistance. Basically, the legislature, we went to the legislature and said, hey, on average, it costs $5,000 to connect a clinic and about $20,000 to $30,000 to connect a hospital. And those aren't fees that really upfront that these facilities want to pay, but there's huge value to that. So the legislature granted us the $21 million and said, hey, anyone who's a provider in the state of Oklahoma can get connected for free. So basically, you can go onto our website, okoshine.ok.gov. You can fill out a connection fee assistance. That's that first orange box there. It's a very short application. We typically approve these within a week, and you will be in line for a grant to, as My Health connects you, all the costs to get you connected from both My Health or your EMR provider will be covered by the state of Oklahoma. This is a great program. We hope it will continue. So I would say though, go out, get your connection fee assistance filed. Everyone who gets that fee filed, I'm pretty sure if we decide to cut the program for whatever reason, that anybody who's in the queue is going to maintain their funding. So even if you think you might back out later, I highly encourage you to consider getting your connection fee established. Next slide. Sid, you got it. Yeah, there you go. Okay. So let's talk about the other incentive. That's our SoonerSelect incentive. So this is a provider incentive. You may have heard of this program. So basically, this is for a certain provider types or in the managed care. So you have to be connected to one of the managed care entities. And you can see kind of the provider types there: advanced practice nurses, mid-levels, mental health providers, licensed behavioral health practitioners, podiatrists, all physicians and specialists and anesthesiologists, all are included. And I'm going to give you a complete list of those provider types in a minute. There are a few exceptions. So this is a directed payments program offered by CMS. If a particular area already gets a incentive through the directed payments, you can't qualify for two. So some of those are those behavioral health services and mental health professionals in a community mental health center. Also, services rendered by a state employed or contracted physician are also excluded. Services at federal qualified health centers, rural health clinics, and IHS tribal clinics are excluded. And of course, our Medicaid population that is not part of SoonerSelect or managed care, such as our ABD population, is also excluded. Next slide. So the way this works now, we just updated this program last year. The first 5 quarters, actually, it was a 5-quarter year. The way CMS did it, we were getting 28% that you could earn. That's been reduced this now on the second year to 22.7% that you can earn. 15.2% of that is an increase in your base fee schedule. For all the Medicaid patients that you see. So you get a 15.2% bonus, basically on top of your fee schedule for all those patients that are in the Medicaid managed care program. And then for HIE, you get an additional 7.5% tacked on to that if you're also an HIE participant. So the way those rules work is you have to be a member in good standing. So basically, you need to go out to MyHealth, make your application, and get in the queue for that to be a member, and then of course get all your agreements, your BA, all those things filed, and be a member with MyHealth. And then you need to be live or demonstrated in progress. Now we do accept portal access only. So and many times it may take more time to get connected to your EMR, scheduling, and so forth. But if you just get that portal access, and typically, I think MyHealth's told me within 14 days of you signing your agreements, they'll typically have your portal access granted and training completed. So, and this is a huge benefit just to get down that, and we will start paying out your incentives. Um, Now, I will say this now that we're in the new year, the first 2 quarters, so starting in July through December, we definitely will not have any metrics. So just being connected or in process of connecting will qualify you. We're looking at sometime in the next year, including a performance metric, meaning that you'll just have to increase you'll actually have to use it. So being connected is not enough. As you can imagine, CMS has said, well, we're paying for people to actually go use the HIE, so you'll have to show usage, and we'll look for that usage to go up some small percentage over time. It won't be too onerous, but we do expect people to begin to use the system more and more and more. So that's kind of where that incentive works. Next slide. Now, I'm just going to show you some examples here. So, and really just focus on these last three columns. I've got a major hospital here. Start with it. So their annual HIE participation cost is 284 or $285,000. Their incentives that we paid out in the first 4 quarters of the program last year was 1.6 million. Okay. If I translate that to what that payout will be this year, that would be 1.3 million. So very, these incentives are very, very good. I like to point out the small clinic here. It's got one provider. It cost them $660 a year to be in the HIE. And last year, they got a $10,000 bonus for being as part of the HIE. And next year, they would end up getting a $8,000 bonus, $7,983. So you can see these incentives are very good. In most cases, if you see any number of Medicaid patients, you're going to get every bit of your participation fee, if not 2 to 3x that or more. So I think it's a great program. We won't always have it. CMS has told us likely this will go through 2028 or 2029. So we've probably got a year or two left on this. So I encourage you to get in and you could get still qualified for the second quarter here if you were able to get at least your participation started before the end of the year. Next slide. I'm just going to flip through these quickly. These are all the physical provider types. So so a lot of people say, well, is this particular type of behavioral health specialist covered? Well, if it's in this list, it is. These slides will be in your packet or they will be sent to you or downloadable from the meeting. So I'll encourage you to go through there if you have any questions. And you can always reach out to us if you have any questions. I did note those exceptions again on the last slide. Next slide. Okay, so impact across Oklahoma. Let's kind of tell you what we've been doing. I know Patty mentioned some of this. Over 600 organizations connected, 130,000 transactions daily. Most months, about 50,000 direct lookups, unique lookups to the HIE. I just want to contrast that. 3 years ago, that number was about 18,000. So we went from 18,000 to 50,000 a month of lookups. So significant activity has increased. The number of people connected has also increased, being providers. SoonerSelect dental and medical MCs are all contracted. They're all trained and connected. They all use ADT care fragmentation as the healthcare authority does. We'd encourage you to look at those. But if you're a part of a MCE, their care coordination teams are actually using HIE as well. Incentives, as we talked about, we granted, I think it's actual numbers, 581 of those grants have been awarded. We have about 200 of those that are still working on connecting, and that number changes on a regular basis. Incentives, like I said, year one, 18.5%, 9.25%. We're into year two, and like I said, CMS has not totally approved this. We are we are we have completed our payouts for year one. So year one, we paid out about 23.5 million. Year two, like I said, we're waiting for CMS approval. However, Q1, we're going to pay that out. We're actually in process of paying that out. And that'll be paid out at the 5.2% and 7.5% for HIE. Coming, of course, like I said, is this utilization metric. Next slide. Some common questions I get. Fees are set by the state designated entity. And so participant pays are all based on organization size and type. So, a primary care physician is not going to pay the same as, a hospital, for example. Connection fees, of course, everything related to your getting connected can be paid by the grant, the connection fee assistance program. And there are lots of incentives, like I said, by provider type that you just saw. Privacy and security get lots of questions there. It's all by HIPAA. Even the SDE policies are actually more restrictive than HIPAA. Providers must be in a treatment relationship to access a record, and they have to attest to that. We don't take any substance abuse, 42 CFR Part 2 data. We don't take psychotherapy notes. None of those go into the HIEs. Provider can mark charts or encounters as sensitive and not send them. And security, of course, the SD is a high trust certified. It's been operating well over 10 years and is a very secure solution. The last thing I like to point out is this is a choice system. Providers have a choice. Patients have a choice. Any patient has the right to opt out at any time, and that prevents all disclosure. There's no break the glass. There's none of those capabilities exist anymore. So once you opt out, your data is not disclosed. That's good news, bad news. That means if you opt out at your mental health professional, you just opted out for your cardiologist and your primary care too. We're working on a system to possibly be able to do that more explicitly, so you could opt out at a particular provider and stay in another. That's coming hopefully sometime next year. Behavioral health patients are a little different in that medical patients, the way the state laws are can be opted in automatically. So in other words, when you go to the doctor, you probably signed a notice of privacy, and that indicated they'd share your information, so they can share that information without your direct consent. Behavioral health patients are different. They must affirmatively consent. So if you go to a behavioral health specialist and they're in the HIE, you're going to have to consent to your data actually being shared by that provider. And then lastly, of course, providers have a choice. We do still accept exemptions. That is out on our website. Although the law doesn't necessarily require that anymore. Everyone has the right to make a choice on this. But you can register for that exemption if you'd like. And sometimes I get the question, well, what if I had filed for an exemption and now I want to get back in? All you need to do is go fill out your application with My Health, or in the case of connection fee, go ahead and reapply for connection fee, and you'll be right back in. And then a lot of people also ask about what if I join and then I decide, 6 months, 8 months, a year in, that I don't want to be a part of it anymore. Like all contracts, there's an out clause. I believe it's a 90-day out clause for that. There aren't any penalties from a Medicaid or an MCO perspective for opting out. However, obviously, any incentives would be possibly prorated for the time that you were in versus the time you opted out. Next slide. Go ahead. So what are our next steps? So I think, our, state funding for HIE has never been greater. We've got a lot of cost performance pressures on providers. The HIE can be a big help on that. There's a lot of incentives to get providers connected. Never before could you do it at literally no cost. In most cases, provider will be incentivized more than the cost, as you saw in my chart. So this is a really great opportunity to get your feet wet, understand the HIE. We haven't seen anyone who tried it who said, that wasn't of value. Everyone typically stays in once they try it. Now we have some risk. Of course, the legislator could pull funding at any time. We think there's a lot of value here, and we hope you'll help us support that. But I think there is always a high risk. There's a lot of demands on state funding. So I would ask you to be timely. If you think you want to be connected, get your application to MyHealth in, get your connection fee in, because being registered will help you maintain that funding. Next slide. So our vision really have everyone have a portable record that they can move across Oklahoma and even across the nation at some point. You can certainly go to myhealthaccess.net. You can scan this QR code to get more. You can also go to okshine.ok.gov and get information on all these options. And with that, I think I turn it back over to you, Sid.
I believe we have one question in the chat. So, is there an onboarding process or implementation service that is provided to a new provider who registers and joins the HIE?
There is. So when you join the Health Information Exchange, you will be assigned a client services representative, and we have a full onboarding process, including training, and it can actually be extended by you to the rest of the team, or we can work with you on figuring out if there's any additional assistance you need.
If you have any additional questions, please put them in the chat now. We can make sure to answer them here. Or we do have contact information available. You're welcome, Annette. We have contact information available here that will also be available again in that PDF format of this presentation that comes through in an email later. So you can easily click on these links here to send an email to our teams, whether it be OKSHINE or the MyHealth staff. But if there are no additional questions, we appreciate everyone for being here today. Thank you again for joining today's HI Office Hours session, and enjoy the rest of your Wednesday.
Thank you.
Thank you.